So, welcome everybody to the CAsToR webinar series. I'm David Mendez from the University of Michigan School of Public Health. And today we have the pleasure to have Dr. Krishna Reddy from the Massachusetts General Hospital and Harvard Medical School, who is going to present his work on microsimulation modeling for the colliding epidemics of tobacco and HIV. So, a little bit about Dr. Reddy. He is a pulmonary and critical care physician at Massachusetts General Hospital and an associate professor of medicine at Harvard Medical School. Dr. Reddy earned an MD from Harvard Medical School and a Master of Science in Epidemiology degree from Harvard's T.H. Chan School of Public Health. He was a Fulbright scholar in Spain and a Fogarty scholar in Peru. Dr. Reddy was awarded funding by CAsToR for a pilot project in 2019 that focused on the adaptation of a microsimulation model to examine e-cigarettes and their potential impact on tobacco smoking behaviors and health outcomes. Dr. Reddy's research interests include tobacco, HIV, tuberculosis, and other respiratory diseases, both individually and in combination. The unifying themes of his research are methods of simulation modeling, epidemiology, and cost-effectiveness analysis to study clinical and economic outcomes in the US and in other countries. The goal of his research program is to provide evidence and model-based approaches to clinical decision-making and public health policy. As I mentioned before, Dr. Reddy is going to talk with us about his research on microsimulation modeling for the colliding epidemics of HIV and of tobacco and HIV. So this we follow this introduction. There's going to be a presentation by Dr. Reddy for 30 to 40 minutes, and then it's going to be followed by a 15 to 25 minutes of Q&A. You please submit your questions via the Q&A feature, and at the end of his presentation, then I'll read that the question to Dr. Reddy. After the webinar ends, you'll be redirected to a 5 minutes evaluation, five questions evaluations, and that would appreciate if you complete. With no much ado, Dr. Reddy, please, the floor is yours.
Thanks very much, Dr. Mendez, for the invitation and the kind introduction. I'm really delighted to have an opportunity to speak about microsimulation modeling for the colliding epidemics of tobacco and HIV. My disclosures: I'm an author for UpToDate, and I receive research funding from the National Institutes of Health and the American Lung Association. As Dr. Mendez mentioned, I also received prior funding by a pilot project award from CAsToR, NCI, and the FDA, for which I'm very grateful. So an outline of what I'll discuss today: model-based approaches to studying the impact of smoking on people with HIV, focusing on life expectancy, lung cancer, and additional considerations for low and middle income countries. And then I'll discuss a new microsimulation model of tobacco use behaviors and outcomes. So why build a simulation model? Many people in this audience are probably familiar with simulation models, but these are some of my motivations for doing modeling research. A simulation model can be used to project long-term outcomes, forecast changes in disease burden, and analyze the comparative effectiveness and cost-effectiveness of individual-level interventions and population-level interventions. An important goal of modeling lies in this last point. I'm a practicing pulmonary and critical care physician, and using modeling research to generate evidence that informs guidelines and then patient care is important to me, and I think it's important to clinical care and to public health. So now I'll move on to model-based approaches to studying the impact of smoking on people with HIV. So in the pre-antiretroviral therapy, or ART era, smoking was not a major cause of disease and death among people with HIV. This is exemplified by a quote from a participant in a qualitative study of smoking among people with HIV in the pre and early ART era. And in this and subsequent slides, you'll see the abbreviation PWH, which means people with HIV. So this participant said, if I live long enough to get cancer, that's great. So this suggests some fatalism. In other words, HIV and AIDS is what's going to kill me, so it doesn't matter if I smoke. Of course, this is no longer the case. Where ART is accessible, there's been a shift among people with HIV from AIDS to non-AIDS diseases, particularly in high-income countries, but also to some extent in low and middle-income countries. These non-AIDS diseases include cardiovascular disease, COPD, and lung cancer and other cancers. And what's a common risk factor for all of these? Smoking, of course. So the tobacco smoking prevalence is extraordinarily high among people with HIV in the US. According to the largest nationally representative study, over 40% of people with HIV who are engaged in care in the US smoke cigarettes. And for reference, the most recent prevalence in the general US adult population is about 13%. Another 20% of people with HIV formerly smoked. So does smoking shorten the lifespan of people with HIV? A lot of people with HIV smoke, and it's well known that smoking is bad for health, but how much does it matter in the face of competing health risks from HIV? And will quitting smoking improve the life expectancy of people with HIV? In the absence of long-term observational data, this is where simulation models can be helpful in comparing the health risks of HIV and smoking and projecting long-term outcomes. This led my colleagues and me to conduct a study where the question was, what is the impact of smoking and cessation among people with HIV in the US? We compared the health risks of HIV with those of smoking. We used the cost effectiveness of preventing AIDS complications, our CEPAC model, which has been used for over 20 years to study HIV outcomes and to inform HIV policy. It's been applied to study many key questions in HIV care, both in the US and in other countries. And some of these analyses include when to start antiretroviral therapy in resource-limited settings, expanded screening for HIV in the US, and analysis of cost effectiveness, and do less harm, evaluating HIV programmatic alternatives in response to cutbacks in foreign aid. Much of this work was led by Ken Friedberg, who's the director of our research group, and by Rochelle Walensky, who was my primary mentor and until a month ago was the director of the CDC. And they introduced me to modeling as a way to generate evidence to inform guidelines in care. More about CEPAC. This is a Monte Carlo microsimulation, or individual patient-level model of HIV disease and treatment. The model tracks individuals over time. As a microsimulation, it has memory, and past events can affect the likelihood of future events occurring. The model follows a monthly state transition framework, wherein individuals transition between different states of disease. For HIV, the transition probabilities depend on CD4 count, HIV viral load, and age. And CD4 count is a measure of the strength of the immune system. People who are adherent to antiretroviral therapy see a monthly decrease in HIV viral load, an increase in CD4 count, meaning a strengthening of the immune system, and a decrease in the risk of AIDS-related diseases and death. The model also includes probabilities of death from non-AIDS causes, and in this study, we added a new feature, that smoking would affect the risk of non-AIDS mortality. We included current, former, and never smoking, And we further stratified former smoking by age at cessation. Our model results, we found that smoking reduces the life expectancy of people with HIV, even with imperfect ART adherence. So this figure shows life expectancy for men with HIV. We generated similar results for women, but for simplicity here, I'm just showing results for men. The 3 bars on the left are men who enter HIV care at age 40. The black bar represents current smokers who continue to smoke until death. The dark gray bar shows former smokers who in this analysis we assumed quit around the time that they enter HIV care and remain abstinent. And the light gray bar shows never smokers. The numbers directly above each bar are the life expectancy, and the numbers in the bubbles are the gain in life expectancy compared with current smokers. So never smokers live 6.7 years longer than current smokers, and those who quit smoking at age 40 gain 5.7 years of life compared with those who continue to smoke. The 3 bars on the right show results for those entering HIV care at age 50. Life expectancy is 69.9 years for current smokers who continue to smoke until death, 73.4 years for those who quit at age 50, and 76.5 years for those who never smoke. Not shown here, we found that people who quit at age 60 still gain over 2 years of life expectancy compared with people who never quit, reinforcing that it's never too late to quit smoking. We also did sensitivity analysis to account for different time points of smoking cessation. For example, what if someone quits smoking 5 years after entering HIV care? We also did multi-way sensitivity analysis. Here's an example of one of those, showing that younger patients with higher initial CD4 counts gained the most from quitting smoking. So these 2 heat maps, the one on the left represents results for men, and the one on the right represents results for women. Along the horizontal axis of each is a CD4 count at entry to HIV care. So the higher CD4 count means a stronger immune system at the start. The vertical axis shows age at entry to HIV care. The numbers in each of the cells, which are a little bit small, demonstrate the life expectancy gain from quitting smoking, meaning former smokers versus current smokers. And the different colors correspond to the magnitude of the gain, with green being the highest and red being the lowest. So the greatest gains are for those with the higher initial CD4 count, meaning to the right on the horizontal axis, and those who are younger, meaning down on the vertical axis. But as I mentioned on the previous slide, even those who are age 60, that's the top row in each of the heat maps, still gain over 2 years of life expectancy from stopping smoking. So these results account for imperfect ART adherence, which remains a very big issue in HIV care. But what about when we focus on those with complete ART adherence who are less likely to die from HIV itself? We found that among people with HIV in the US who adhere to ART, the life expectancy loss from smoking is about double that from HIV. We found that men lost 8.6 years of life from smoking and 3.5 years from HIV, while women lost 8.2 years of life from smoking and 4.3 years from HIV. These results are for those who enter HIV care at age 40 and quit smoking around that time. So what do these numbers mean in context? Are these big gains or small gains or something in between? We found that the life expectancy gains from smoking cessation are enormous compared with commonly employed interventions. Here on the vertical axis are per person survival gains in months, and each bar represents a different intervention. The 2 bars in blue represent the survival gain from smoking cessation at age 40 for a man with HIV and for a woman with HIV. And this accounts for typical rates of non-adherence to ART. If we focus on those who are adherent to ART, then the blue bars would be even higher. Nonetheless, this graph shows that smoking cessation results in very high gains compared with other interventions in the general population, such as treating everyone with a statin, giving clopidogrel for secondary prevention of cardiovascular events, trastuzumab for HER2-positive metastatic breast cancer, and chemotherapy for metastatic lung cancer. And the last bar on the right is the life expectancy gained from novel antiviral drugs for hepatitis C, which have been revolutionary in curing hepatitis C for many. However, this shows the life expectancy gain from these hepatitis C treatments is still less than that from smoking cessation. So these results might seem obvious to some, but it was news to others. Here were some headlines in the lay press after our study was published. So from NBC News, smoking more likely to kill HIV patients than the virus. And from Vice, for those with HIV, cigarettes have become more dangerous than the actual virus. Now, further down, they write that this is among people who are on ART. For people with HIV, ART is still certainly priority number one. But after that, I would argue that smoking cessation is a critical intervention. So smoking clearly is a threat to survival, but what about its impact on specific diseases, such as lung cancer? So let's examine lung cancer more closely. Lung cancer is now the leading cause of cancer-related death among people with HIV in high-income countries. This was shown in NA Accord, which is a consortium of cohorts of people with HIV in the US and Canada, where lung cancer was number one over 267,000 person-years of follow-up. In France, a study of about 82,000 people with HIV found that lung cancer was the most common cancer-related cause of death in 2010, and it represented the leading cause of death in people living with HIV overall. So more than any opportunistic disease, more than ischemic heart disease, lung cancer was number one. Now, some might say that that's because smoking is so common in France. And while it's true that smoking prevalence is higher in the general population of France than it is in the general population of the US, when we look at people with HIV, the smoking prevalence is pretty similar between the two countries. So what accounts for the rising burden of lung cancer in people with HIV? First, there are fewer AIDS-related deaths as more people are gaining access to effective antiretroviral therapy. Second is the aging of the population of people with HIV. Third, and critically, is the high prevalence of tobacco smoking, as shown earlier. One study found that 94% of lung cancer cases in people with HIV are attributable to smoking. There's also been interest in investigating whether HIV is an independent risk factor for lung cancer. These are data from a US Veterans Affairs study in which they compared lung cancer incidence among veterans with HIV to veterans without HIV, stratified by smoking status. Overall, they found that HIV increased the risk of lung cancer by a factor of 1.7, which was fairly consistent across never smokers, former smokers, and current smokers. Nonetheless, it's important to remember that smoking is still the dominant risk factor for lung cancer. HIV, according to this study, increases the risk of lung cancer by a factor of about 1.7, while smoking increases it by a factor of 25. My colleagues and I were interested in predicting the cumulative risk of lung cancer as a function of smoking exposure. We also asked, how does the expected cumulative mortality from lung cancer compare to that from AIDS? Our goal was to perform a modeling analysis that could help clinicians and patients recognize the relative risks of dying from lung cancer versus from AIDS. So I showed earlier causes of death in the CEPAC model, which include AIDS-related causes of death and non-AIDS-related causes of death. And we had previously stratified the non-AIDS causes of death by age, sex, and smoking status, current, former, and ever, and we had stratified the former smokers by age at cessation. For this lung cancer analysis, we additionally stratified smoking-associated mortality by the intensity of smoking, heavy, moderate, or light, based on cigarettes per day. And our data sources had indicated that heavy was about 2 packs a day, moderate was about 1 pack a day, and light was 2 to 3 cigarettes per day. We stratified non-AIDS deaths into 2 categories. lung cancer, and everything else. So other non-AIDS, non-lung cancer deaths, such as cardiovascular disease. For lung cancer, we accounted for both the smoking attributable risk and the HIV attributable risk. Our CEPAC model results, we found that about 1 in 4 ART adherent smokers in the US will die from lung cancer. This plot shows model-generated lung cancer mortality results starting at age 40 for men with HIV according to their smoking status. The black lines represent current smokers who continue to smoke until death. The blue lines are former smokers who quit at age 40, and the red line is never smokers. The different grades of the black and blue lines indicate smoking intensity, heavy, moderate, or light. So the black dashed line represents current moderate smokers, so the average smoker, and this shows that lung cancer mortality by age 80 is close to 25%. So how does the risk of dying from lung cancer compare with the risk of dying from other causes? We found that ART adherent men who smoke are 10 times more likely to die from lung cancer than from AIDS. This plot depicts those who smoke, looking from ages 40 to 80. And again, I'm only showing men here, though we generated similar results for women. The black dotted line is cumulative AIDS mortality by age 80, which is 2.3%. The red dashed line is cumulative lung cancer mortality, which is 23%. So the red line mortality is 10 times higher than the black line mortality. The blue solid line is death from all other causes, such as cardiovascular disease and other cancers, many of which are also influenced by smoking. The good news is that smoking cessation helps. If we look at those who quit smoking at age 40 in the right panel, lung cancer mortality, which is the red line, has decreased from 23% to 6.1%. The blue line has also decreased because many of these causes of death are also less likely after quitting smoking. At the population level, we found that nearly 10% of people with HIV will die from lung cancer if smoking habits don't change. We came to this estimate first from an estimate of 644,000 people with HIV, aged 20 to 64, in care in the US. Now, the total number of people with HIV in the US is considerably larger than this, but this also is limited to those who are between age 20 to 64, who are diagnosed and who are engaged in HIV care. We estimated that there would be about 60,000 lung cancer deaths by age 80 if smoking habits don't change. And if 20% of current smokers were to quit now, about 12% of lung cancer deaths could be averted. It's 12% and not 20% because people who quit smoking still have an elevated risk of lung cancer mortality compared to never smokers. So what are the implications of all these findings about smoking and its impact on the health of people with HIV? We hope they may provide patients with HIV with greater motivation to quit smoking. And for providers in HIV care programs, we hope that more attention and resources will be directed towards smoking cessation programs. Future modeling studies can reveal the cost effectiveness of smoking cessation interventions in HIV care. Unfortunately, the HIV primary care guidelines have said little about smoking and smoking cessation. This is the version of those guidelines from 2013. It's a very detailed 30-page document, and the first mention of smoking is at the bottom of this table on page 27. It's in the red box under patient education, the bottom right corner. Further up in this table are things like ophthalmologic exam and trichomoniasis screening. So smoking had emerged as the leading killer of people with HIV in the US, and its first mention was on page 27 of this document. Now, there's a more recent version of the guidelines released in 2021. It mentions smoking a bit sooner, but there's still no guidance for providers on how to help people with HIV quit smoking. DHHS guidelines do have a little bit more detail about smoking, and they cite modeling studies showing the harms of smoking and benefits of cessation in people with HIV. So this motivated us to write a paper about tobacco use among people with HIV with practical guidance for clinicians on how to help people with HIV stop smoking. This was published last year in Clinical Infectious Diseases. Next, I'll move on to additional considerations for low and middle income countries. There's a high prevalence of tobacco use among people with HIV in low and middle income countries. This study in 28 low and middle income countries in Africa, Asia, and Latin America found that the tobacco use prevalence is 40% higher in relative terms in people with HIV compared to people without HIV. In low and middle income countries, there are colliding epidemics of tobacco, HIV, and tuberculosis, or TB. TB is the leading killer of people with HIV worldwide, and smoking increases the risk of TB pathogenesis. Specifically, smoking increases the risk of TB infection, progression to active TB disease, poor response to TB treatment, relapse of TB, and death from TB. And smoking contributes substantially to global TB burden. This is a modeling study from another group, which found that smoking would produce an excess of 18 million TB cases and 40 million TB deaths worldwide between 2010 and 2050. Meanwhile, globally, there have been calls from the World Health Organization, the United Nations, and the National Institutes of Health to integrate tobacco control into TB and HIV responses. They've noted that tobacco companies have targeted low and middle income countries, which have a growing population of young people with money for tobacco products. Also, tobacco regulations in these countries are often lax. Low and middle income countries are home to 80% of the world's population of people who smoke. This motivated us to investigate smoking and life expectancy among people with HIV in South Africa. Over 7 million people with HIV live in South Africa. And in fact, that's the highest number of any country in the world. And the smoking prevalence in South Africa is about 8% among females and 37% among males. So we conducted a modeling study whose objective was to estimate the impact of tobacco smoking and smoking cessation on life expectancy among people with HIV in South Africa, accounting for background mortality rates in South Africa, access to antiretroviral therapy, and adherence to antiretroviral therapy. So using the CEPAC model, we found that smoking substantially decreases the life expectancy of people with HIV who are on ART in South Africa. This figure specifically shows model results for females with virologic suppression on ART at the start of the simulation, according to smoking status and their age at entry to HIV care. We still account for subsequent incomplete adherence to ART and disengagement from care among some. In this figure, for example, among 45-year-old women, that's the middle three bars, life expectancy is 68.9 years for people who currently smoke, 72.3 years for people who formerly smoked and quit at age 45, and 74.2 years for people who never smoked. Overall, we're finding that the impact of smoking and cessation on life expectancy among people with HIV in South Africa is a little less than it is in the US, probably for a couple of reasons. One is higher competing risks of mortality in South Africa. And second is a lower quantity of cigarettes consumed per day among people who smoke in South Africa compared to the US. And of course, the dose-response relationship with cigarette consumption and disease and mortality risks. Nonetheless, smoking cessation is a pretty low-hanging fruit for which HIV care infrastructure in low and middle-income countries could be leveraged. Indeed, our model results show that smoking reduces life expectancy more than HIV among people with HIV on ART in South Africa. So among people with initial virologic suppression, meaning their HIV is under control, but who subsequently have average ART adherence and average engagement in HIV care, females lose 5.3 years of life from smoking and 3.0 years of life from HIV. while males lose 3.7 years of life from smoking and 2.6 years of life from HIV. These are heat maps showing two-way sensitivity analysis and demonstrating that the impact of smoking and smoking cessation increase as smoking-associated mortality risks increase and as HIV-associated mortality risks decrease. So these two heat maps, the one on the top is females who enter the model at age 45, and the bottom is males entering it at age 45. Across the horizontal axis of each is the monthly probability of disengagement from HIV care. So as you go from left to right, that probability increases, which means people will be more likely to stop taking antiretroviral therapy and then more likely to face risks of disease and death specific to HIV. The vertical axis is the mortality hazard ratio for people with current versus never smoking status. We varied that from 1.2 to 3.0, given some uncertainty around what this hazard ratio is in South Africa. The numbers in each cells represent the life years gained from smoking cessation, and the colors correspond to magnitude, blue being the most. So the biggest gains are among those who are on the left of the horizontal axis, meaning a low probability of disengagement from HIV care or the low likelihood of dying from HIV-specific causes. And in the cells that are on the top of the vertical axis, meaning a higher mortality hazard ratio for current versus current versus never smoking status. The implications of these findings, we found that among virologically suppressed people with HIV in South Africa, tobacco smoking decreases life expectancy more than HIV itself. If 10 to 25% of virologically suppressed people with HIV aged 30 to 59 in South Africa stopped smoking now, between 190,000 and 460,000 life years would be gained. And integrating tobacco cessation interventions into HIV care, as endorsed by the World Health Organization, could substantially improve life expectancy. Next, I'll describe a new microsimulation model of tobacco use behaviors and outcomes. Some of the motivation for this was in differentiating between smoking cessation and a quit attempt. Many existing models equate one-time smoking cessation with permanent abstinence from smoking. But in reality, most smokers face repeated cycles of quit attempts and relapses before they sustain abstinence. 10 to 20% of quit attempts actually result in abstinence. This is exemplified by a quote attributed to Mark Twain, which is on the right. "Giving up smoking is easy. I've done it hundreds of times." So we envisioned a model that would reflect the natural history of smoking quit attempts with a goal of evaluating the clinical and economic outcomes and cost effectiveness of smoking cessation interventions. So we built a new tobacco simulation model called the Simulation of Tobacco and Nicotine Outcomes and Policy, or STOP model. Regarding the STOP model structure, it's a microsimulation model, Monte Carlo, similar to CEPAC, in which individuals are simulated over their lifetime. It follows a state transition framework where each state is associated with morbidity and mortality risks and healthcare costs. The model has a monthly time cycle and thus can capture cycles of quitting and relapsing. STOP model input parameters can be stratified by age, sex, and tobacco nicotine use status. These parameters include initiation, cessation, and relapse probabilities, morbidity and mortality risks, quality of life, and healthcare costs. The STOP model outputs include prevalence of tobacco or nicotine product use at different time points, cumulative incidence of a particular disease, life expectancy, healthcare costs, and cost effectiveness as measured by an incremental cost effectiveness ratio. We conducted a calibration and validation analysis of the STOP model structure, which was published, and we validated STOP model results for prevalence of current, former, and never smokers over time with those of the CISNET model and with empiric data from the National Health Interview Survey, accounting for differential mortality by smoking status. We derived transition probabilities and smoking stratified mortality rates from the National Health Interview Survey and the linked National Death Index. This is a simplified schematic of the model states and transitions in the STOP model. So an individual can start as a never smoker. Initiation of smoking leads them to the current smoker state. And then from there, they can continue in that state, or they can make a quit attempt. Then they move to the recent quitter state. And from there, if they maintain abstinence, they transition to the former smoker state. People in the recent quitter or former smoker state can relapse and become current smokers again. And the different weights of the arrows here can sort of represent the likelihood of those events happening. So recent quitters are more likely to relapse than former smokers are to relapse, and that's why the arrow weight is thicker there. And from any of these states, an individual can die, and the likelihood of that happening depends on their smoking status. Here again, the current smokers and recent quitters have the red arrows with the thickest or heaviest weight because they have the highest probability of dying, and followed by former smokers and then never smokers. The methods of our calibration and validation exercise and quit attempts and relapse. First, we excluded smoking relapse from the STOP model. We only included initiation and sustained abstinence, similar to the CISNET model. Second, we incorporated relapse. And third, we calibrated cessation probabilities by a multiplier to account for repeated quit attempts prior to sustained abstinence. Our calibration targets were the smoking prevalence as reported by the CISNET model and by the National Health Interview Survey. So the smoking prevalence from the CISNET model, which includes smoking initiation and cessation, but meaning abstinence, but not relapse. This plot on the horizontal axis is age, on the vertical axis is current smoking prevalence. And this shows current smoking prevalence for men born in 1930 in the US. Here, the dark yellow line shows STOP model results without relapse, meaning initiation and abstinence only, and they match the CISNET results well. However, now the peach line includes relapse in the STOP model, and this shows that current smoking prevalence is now much higher before calibration. And this is because we're among many of the people who quit smoking, they will relapse. And so the current smoking prevalence is higher than previous estimates. Now, in this last step, we calibrated smoking cessation probabilities to account for the multiple quit attempts and to better match smoking prevalence data. So the red line here is now close to the CISNET data and close to the dark yellow line from step one. These STOP model results after calibration also validated well with the raw data from the National Health Interview Survey, which I haven't shown here. Some recently completed, ongoing, and upcoming STOP model analyses. First, we're using the model to study tobacco use and health disparities in the US. A manuscript of this has been submitted and is under review. Second, with support from the American Lung Association, we're investigating the impact of e-cigarette and combustible cigarette taxes on tobacco product use in the US. Third, we're studying tobacco use transitions in South Africa and actually doing primary data collection with colleagues in South Africa. And fourth, we'll use the model to study the clinical and economic outcomes of incorporating tobacco cessation interventions within HIV care in South Africa. A bit more about the work in South Africa. I've been working with colleagues at the Africa Health Research Institute in KwaZulu-Natal, Eastern South Africa, on a study of tobacco use among the large Vukuzazi cohort of about 18,000 people in rural South Africa. Our preliminary findings reveal that among people with HIV who use tobacco, only 6% have ever been advised to quit by a healthcare provider. And in this cohort of 18,000 people, about 1/3 are people with HIV. So this highlights that there are global opportunities to study and improve tobacco cessation services and to improve health. And meanwhile, separate from the ongoing study of the Vukuzazi participants, we've been using simulation modeling to analyze clinical and health economic outcomes of tobacco use among people with HIV in South Africa. I showed the results of our first analysis a few minutes ago, showing that smoking reduces life expectancy more than HIV itself among people with HIV on ART in South Africa. So some key points, which I hope you'll take away from this. First, smoking reduces life expectancy more than HIV among people with HIV who are on antiretroviral therapy. Second, smoking cessation should be prioritized in the care of people with HIV. And third, models can inform guidelines and policy in tobacco and HIV by projecting disease burden and the impact of interventions. I'd like to thank collaborators at several institutions, as well as the National Institute on Drug Abuse, the National Institute of Allergy and Infectious Diseases, and the American Lung Association for funding our work. And of course, thank you to CAsToR, NCI, and the FDA Center for Tobacco Products for supporting our modeling work through a pilot project award a few years ago. Thank you to David Mendez of the University of Michigan for his support over the years and for inviting me to speak today. So I'll conclude there. Thanks again. I'll be happy to take questions and comments. Thank you.
Thank you very much, Dr. Reddy. That was a magnificent presentation. So, so now we have times for Q&A, and I'm going to read the questions that came to our chat. First question is, why is the life expectancy higher for those entering HIV care later?
Yes, good point. And the way that I define life expectancy here is really age at the time of death, which is not the way that it's usually defined, where it's life expectancy would be age from the time that one starts the observation. So it's really age at the time of death. So those who are entering HIV care later, there's basically a survival bias, like they've already survived enough time to reach age 55, for example, rather than 45. So from age 55 to the time of death, it's actually shorter than those entering at 45. But for the audience of these journals, we thought that age at the time of death was a little easier to interpret.
Thank you. Another question we have is there any interaction between HIV and smoking in terms of relative risk? That means that is a person with HIV more likely that smokes, more likely to have a smoking-related disease or die of a smoking-related disease than a person that doesn't have HIV?
Yeah, it's a very interesting question and one that's been investigated. I think the bottom line is that it's not quite clear. There are some data suggesting that people with HIV will develop lung cancer or COPD at lower levels of tobacco smoke exposure compared to people without HIV. And there's some suggestion that the HIV virus itself and tobacco smoke might have synergistic harms, such that the two of them together causes more harm than just the sum of them. But the studies are limited by confounding. Like it could be the case that the people with HIV are consuming more cigarettes per day than people without HIV. There are also other factors which might contribute to COPD and lung cancer risk that are not measured. So it's not really clear. And I remember one person telling me when I mentioned this, like, hey, people with HIV might be more susceptible to the harms of smoking than people without HIV. This person said, well, even if they're not, it doesn't really matter. The bottom line, the policy implication remains the same, that like we need to help people with HIV quit, even if the harms of smoking are no greater in them than they are people without HIV.
Thank you. Very interesting. Another question. Have you included e-cigarette use in any of your models? And if so, what is the assumption? What are the assumptions? What assumption did you use?
Yeah, so I haven't shown our e-cigarette analyses here. So we haven't investigated e-cigarettes in people with HIV at all. But we are doing some stop model analyses of e-cigarettes. For example, one that I mentioned on one of the last slides was about the impact of taxes on e-cigarettes and on tobacco cigarettes, on downstream use of e-cigarettes and tobacco cigarettes. And for that, we had to expand the stop model by quite a bit. Instead of just having 3 states, current smoker, former smoker, never smoker, we ended up with, I think, 27 states. And so for current smokers could be current e-cig users, former e-cigarette users, or never e-cigarette users, and it goes on for each of the different states. So we've done some calibration of transition probabilities around each of those states using data from the PATH study. And we actually published our validation of that using multi-state modeling methods earlier this year. And so we're now using that model structure to evaluate tax policies. But that's not in people with HIV. It's in the US general population.
Thank you. Another question is, why is that high prevalence of smoking in HIV patients higher than in the general population?
Yeah, that's also very interesting, and I think there are multiple reasons for it. One is that some of the same factors that tend to be associated with tobacco smoking are also associated with HIV. So those are things like lower socioeconomic status, lower education level, race and ethnicity, and many other states of many other causes of disadvantage. So those tend to be found in both. Second is that there are high rates of mental health issues in people with HIV, so mood disorders like depression and anxiety, and of course smoking prevalence tends to be higher in those people. Third is that issue of fatalism that I mentioned earlier, that quote from that patient from the 90s who asked about their smoking, said, well, if I live long enough to get cancer, that's great, right? So there's this I think among some patients with HIV, there's still this thought that, well, I have HIV, that's my biggest problem, and that's what's going to kill me. It doesn't really matter if I smoke or not. And fourth is an issue on the part of providers. This is a big motivation for some of the work that I do. A lot of my fellow clinicians, even those who are very focused on HIV and spend a lot of time caring for people with HIV, like the smoking just isn't at the top of their problem list, so to speak. And it's understandable, you got a short visit with a patient, and providers tend to be very focused on the HIV parameters and, is the virus suppressed? And then the fact that this person is smoking often falls like further down on the list and it's not addressed. There's also studies indicating that HIV care providers are less confident in their ability to influence smoking behaviors among their patients compared to non-HIV care providers. And a lot of HIV care providers aren't comfortable in prescribing tobacco cessation medications, for example, compared with primary care providers for people without HIV. And that was one of our motivations for writing the paper. I didn't go into the details of it, but I just showed the title. It was published last year, to really provide practical guidance for providers of care for people with HIV on how to help people quit smoking. Here are the resources for behavioral therapy. Here's how to prescribe varenicline. This is the dose, and this is in whom it should be given. And there was actually a clinical trial, randomized trial, specifically in people with HIV, where they were randomized to either varenicline plus counseling or placebo plus counseling, and showing an odds ratio of about 2.5 for smoking abstinence among those who got varenicline.
Very interesting. It's like if you pay attention to HIV and that's it. That's you don't have to worry about. And what you have demonstrated is that smoking catches you faster than HIV, right?
Right. And when I was a fellow in pulmonary and critical care medicine, I would get consulted to see patients with lung disease, some of whom had HIV. And the lung diseases that I was seeing in Boston were not tuberculosis or pneumocystis pneumonia or the lung diseases that people with HIV got in the 90s, but it was lung cancer and COPD. It was all effects of smoking. And so that's really what motivated me to study this further.
Let's see. Another question here. It seems like cessation interventions among people with HIV in the US or in middle or low income countries are needed. Do you see yourself moving away from modeling and focusing on the ground implementation studies?
Yeah, that's interesting. And certainly we need implementation studies. I don't see myself moving away completely from modeling. I really enjoyed modeling. I think it's a way to conduct research that has an impact on guidelines and policy. Getting back to what I showed earlier about evidence informing guidelines, which then influences patient care. But what I do like to do is partner with people who do implementation studies, and so that's some of the work we're doing now in South Africa with colleagues there. I'm never going to be able to run an implementation study in South Africa as well as someone who is based in South Africa can do it. But the comparative advantage that I have is in modeling studies, and they want these modeling studies to then present to their Department of Health and the Ministry of Health to show what kind of impact this will have at the population level, how much it will cost the Ministry of Health. So that's where we have nice partnerships between people who do modeling research and those who can do implementation studies.
So another question we have is how challenging is it to calibrate the model to other countries? Could it be applied to, say, Uganda easily?
Yeah, interesting point. So for the CEPAC model, the HIV model, that's been used in a number of countries: U.S., France, Brazil, South Africa, India, Zimbabwe, using data specific to those countries. So data about adherence to antiretroviral therapy, data about incidence of tuberculosis and HIV-associated diseases and death. So it's all dependent on the data. And for HIV, we do have data from those different countries. For smoking, it's a little harder, as you can imagine. There aren't great data about risks of tobacco in Uganda, for example, or how often do people in Uganda who smoke attempt to quit. Even in South Africa, which is middle income, not low income country, and where there's a pretty good research infrastructure, there actually aren't great data about transitions in tobacco use. And that's part of why we're actually now doing primary data collection in South Africa. We've surveyed people in that Vukuzazi cohort study of 18,000 people about tobacco use and about changes in tobacco use over time to better understand how often people start or quit or relapse. So if we have the data, then we can use those data in the model in almost any country.
Great. One more question. You focus your analysis on people mostly suppressed on ART. However, does smoking independently reduce one's probability of reaching viral suppression? Is smoking a risk factor for virologic failure?
Yeah, really interesting point, and in another area of investigation. So I think the bottom line is we don't know. There are some studies suggesting that when you compare people with HIV who smoke to people with HIV who don't smoke, the people who smoke are less likely to attain virologic suppression. Virologic suppression means they're taking their medicine, and when you check their blood, you don't see the virus there. Their HIV is under control. And they found that even when they've controlled for potential confounding factors that they could control. So this suggests that there may be something about the inflammation that's induced by smoking that might impair the immune system's ability to keep HIV under control, even in the presence of the drugs. But as you can imagine, there are confounders there, like people with who smoke are also less likely to be adherent to the therapy, to the drug. So it may just be that they're not taking the medicine. So we don't know, but it's an active area of investigation.
Right. One more question. A great talk. Any suggestions on this line of research among pregnant women?
Yeah, it's a really important point. So there's certainly studies of tobacco cessation among pregnant women, and there's guidelines for both behavioral and pharmacologic interventions for pregnant women who smoke. I don't know of any studies of tobacco use or tobacco cessation among pregnant people with HIV specifically, at least not any large studies. So I think for pregnant people with HIV who smoke, the guidance would be fairly similar to that for pregnant people without HIV who smoke.
Thank you so much. Well, those are the questions we have, and we are pretty much about out of time. So thank you very much for a wonderful talk and for answering all these questions. And we hope that we'll be able to have you back in a future webinar. Thank you very, very, very much for your presentation today.
My pleasure. Thank you, David, and thanks everyone for joining.